Assalamualaikum and a very good day everyone. I'm Dr. Hidayah Shafi'i, an emergency physician from ETD HKL. So today I'm going to deliver the last lecture in basic PoCUS series, which is the Ultrasound Protocol in shock. So at the end of this lecture, we should be able to incorporate the systematic ultrasound assessment during shock resuscitation to rapidly recognize the reversible cause of shock and intervene timely, in hoping to improve the diagnostic accuracy, especially when we are dealing with undifferentiated shock. As a recap, shock is the state of hypoperfusion caused by inadequate oxygen delivery due to the abnormal circulatory system. And as we know, there are 4 types of shock. The most common encountered in critically ill patients is distributive shock due to sepsis, followed by cardiogenic and also hypovolemic. Obstructive shock is the least commonly encountered. Shock can be resulted from 4 potential pathophysiological mechanisms. It can be due to hypovolemia from internal or external fluid loss, a cardiogenic factor, for example in the cases like acute myocardial infarction, end-stage cardiomyopathy, myocarditis or any arrhythmia. Shock can also be due to obstruction to the venous return or obstruction to the stroke volume which is being ejected from the LV in the cases like pulmonary embolism, cardiac tamponade or tension pneumothorax. And it can also be distributive in nature, for example in septic shock, anaphylaxis or drugs overdose. Hypovolemia, cardiogenic and also obstructive shock compromise the stroke volume and the heart rate, hence giving rise to low cardiac output, while distributive shock produces high cardiac output due to its low peripheral vascular resistance. However, in the late state of sepsis, there can be myocardial depression, hence giving rise to low cardiac output in distributive shock. A diagnosis of shock can be based on clinical, hemodynamic and also biochemical signs. Firstly, shock can be manifested as systemic arterial hypotension. Secondly, there are clinical signs of tissue hypoperfusion which are apparent through 3 windows of the body: the skin, the brain and also the kidney. Okay? When there is hypoperfusion to the brain, it can be manifested as altered mental status, which typically includes obtundation, disorientation and also confusion. The low perfusion to the kidney produce oliguria, and hypoperfusion to the skin is manifested as cold and clammy due to the vasoconstriction and also the rerouting of the blood from the skin to other vital organs. Thirdly, hyperlactemia is typically present, indicating abnormal cellular oxygen metabolism. So what is the role of point-of-care ultrasound? PoCUS act as the adjunct to differentiate the type of shock by assessing mainly the heart, lungs and also abdomen. And this is very pertinent in the emergency setting because we normally deal with undifferentiated shock as patients land in our department acutely without prior history or clinical information. Point-of-care ultrasound has many roles in the assessment of shock. Not only it helps us to identify the type of shock and the cause of the hypotension, it can also facilitate us to evaluate the fluid adequacy, the fluid responsiveness, tolerance and also effectiveness. We can look at the cardiac function, the state of the lungs, whether it is wet or dry, and the state of the kidneys, whether the patient have pre-existing kidney abnormalities or not. These can give us an idea of the patient tolerance towards our fluid resuscitation. And apart from that, point-of-care ultrasound also help us to assess the requirement of inotropic or vasopressor in shock patient. So what is ultrasound protocol? It is actually a systematic physiological roadmap ultrasound that allow us to conduct the PoCUS in a systematic way, hence preventing us from missing any major pathology in the heat of resuscitation. There are numerous protocols, most of them combine the same core ultrasound element, however with a different priority and also sequences. So one of the most common ultrasound protocol used is the RUSH protocol. So RUSH, which stands for Rapid Ultrasound in Shock Protocol, is a goal-directed protocol with the objective of rapidly finding the cause of shock, treat, hence reducing the patient's mortality. This protocol is an assessment based on three physiological systems, which are the pump or the heart, the tank, which involve the lungs and also the abdomen, and the pipes, which comprise the arterial and also venous system. So the pump involves the assessment of the pericardium surrounding the heart, the left heart function, and also the state of the right heart. The tank assessment include looking at the fullness and also leakiness of the tank, or whether the tank is being compromised, for example in tension pneumothorax. Lastly, the pipe evaluation involve looking at the evidence of any leakiness of the arterial system and also obstruction of the venous tributaries. So now let us look at the pump or the heart. First and foremost, to assess the pump, the probe that we use is the cardiac probe. We view the heart at the parasternal long axis and short axis, the apical four chambers, and also the subxiphoid view. So how do we assess the pump? The first step is to look at the surrounding of the heart to confirm the presence of pericardial effusion and cardiac tamponade. So if the effusion is present, then we will look at the size and also the color. A small effusion will appear like thin stripe in the pericardial space, while a larger effusion will be visualized as hypoechoic collection surrounding the heart. You may also find loculated effusion in patients with a traumatic cardiac injury or post-cardiac surgery, and also purulent pericarditis. A dark-colored effusion suggests fresh blood, while hypoechoic denotes clots or exudates. So once we have confirmed the presence of effusion, the next step is to assess whether the effusion causes tamponade or not. Cardiac tamponade is defined as increase in intrapericardial pressure, which prevents the expansion and filling of the RV during diastole phase due to its relatively lower pressure as compared to the left heart. This clip shows an example of cardiac tamponade. In clip A, which is the parasternal long axis, you can see pericardial effusion surrounding the heart. So this exert pressure to the RV because the RV appear compressed. So you can determine the phase of the cardiac cycle by looking at the mitral valve. So early diastole starts when the mitral valve opens. Clip B shows the heart is floating in the pericardial effusion. This is a parasternal short axis, and you can see the RV also being compressed here. Clip C is the apical four-chamber view, when you can see the right side of the heart hardly open up during diastole, hence compromising the venous return and subsequently reducing the stroke volume. So IVC can also help to facilitate the diagnosis of cardiac tamponade because the pressure being exerted onto the RV and also the RA. So there would be no venous return or lack of venous return into the RA. Hence, the IVC appears dilated and also fixed, as being shown by the still image in picture D. So the next step of assessment of the pump is to look at the left ventricle contractility. This is an assessment of the strength of the pump that can guide us for fluid resuscitation. It involves the visual estimation of volume change from diastole to systole of the left ventricle. So good contractility denoted by a large volume change. If you see the LV, area or volume, reduced by 50% during diastole to systole, so that deems as a normal contractility. If the change is less than 30%, so it can be labeled as poor. So the numbers or percentage in between 30 to 50% is denotes as abnormal. If you see the chamber size very small with a vigorous and hyperkinetic contraction which obliterate the ventricle during systole, so that we can call as hyperdynamic, and this is a pattern of hypovolemia. So these clips denote a normal contractility when you can see the LV or the myocardium shorten and also thicken simultaneously towards the center, and the volume change is around 50%. While this clip, the right and upper clip, shows abnormal contractility, the left lower clip shows a poor contractility when you can see the heart is hardly contracting. So the last clip, the lower right side, shows an obliteration of the LV and also RV during systole, which denotes lack of volume in the chamber. So this is a pattern of hypovolemia. The third step of palm assessment is to look for evidence of right heart strain pattern. If a patient is in shock in the presence of RV strain, pulmonary embolism should be suspected. The signs of acute pulmonary embolism includes RV dilatation, and because of the high pressure in the RV, so you may see deflection of the interventricular septum towards the left ventricle with fixed IVC. The only chamber that can dilate in acute setting is the right ventricle. A dilated and hypertrophic RV is a sign of chronicity which is expectedly to be accompanied by RA dilatation. These clips show RV strain pattern where the RV is dilated, as you can see in clip A. The RV ratio to ascending aorta and LA is more than 1. In clip B, you can see the evidence of increased pressure in the RV as the interventricular septum is being pushed toward the LV. While the clip C, which is an apical 4-chamber view, the RV size is similar to the LV size. There may be an evidence of chronicity as the RA appears a bit dilated. IVC can facilitate the diagnosis of pulmonary embolism with its dilated size and lack of respiratory variations, denoting increased pressure in the right heart chamber, as you can see in clip D. These are the example of chronic pulmonary hypertension. In both clips, the RA and RV are significantly dilated. Patient B is also having RV failure. As you can see, the longitudinal right ventricle contractility is depressed. Now we have completed the palm assessment. The next step would be evaluating the tank, which consists of the thoracic and also abdominal cavities. Tank assessment use the curvilinear or abdominal probe to look at the IVC, intraperitoneal, and also the thoracic cavities. The first element of tank assessment is the fullness, which denotes a patient volume status. This can be determined by the size and variation of IVC and also internal jugular vein. IVC or IJV variation is a product of heart and lungs interaction. During spontaneous breathing, when the patient inspires, the intrathoracic pressure decreases, hence increasing the venous return into the RA, leaving IVC collapse. While in ventilated patient, positive pressure ventilation or inspiration causes increased intrathoracic pressure instead, and this leads to the distension of IVC. Hence, collapsibility of more than 50% in a spontaneously breathing patient, or distensibility of more than 15% in intubated patient indicates there is still room for fluid infusion. You can actually estimate CVP based on the size of IVC and its variation with respiration. An IVC diameter of less than 2 cm with a collapsibility of more than 50% tells you that the CVP estimatedly between 0 and 5 mm mercury. A fixed and dilated IVC of more than 2 cm is highly suggestive of high CVP with a mean of 15 mm mercury. Now, a flat IVC denotes volume depletion, but does a fat IVC tell us that the patient is volume overload? IVC size and variation is a parameter with so many caveats. It is inaccurate in pulmonary hypertension in a patient with left ventricular hypertrophy or valvular heart disease. It is less accurate in spontaneously breathing patient. It is actually more accurate in passively ventilated patient with a tidal volume of 6 to 8 mL per kg. Therefore, we have to be very careful with the IVC interpretation as it has a lot of influencing factors. If we cannot obtain IVC, IJV assessment can be the alternative. We can obtain IJV by putting the patients elevated at 30 degrees, scan using a linear probe as it is a superficial structure. The principle is still the same. We assess the diameter and also the fullness of IJV with the percentage of change with respiratory dynamics. Image A shows a dilated IVC with lack of respiratory variation, while image B shows a collapsed IJV which denotes volume depletion. Remember your septic patient or your severe burn patient that you have difficulty to visualize the internal jug during CVC insertion? Yes, that is highly suggestive that they are hypovolemic. After we have determined the volume status, the second step is to assess the leakiness of the tank, especially when the patient is hypovolemic. These involve the assessment of thoracic and also abdominal cavity for the presence of fluid. A positive fluid in the thoracic or abdominal cavity in a trauma patient in shock is suggestive of hemothorax or intra-abdominal injury respectively. A positive fluid collection in the pleural cavity in a non-trauma patient may indicate heart failure or tank overload. However, a similar finding in dengue shock patient indicates leakage syndrome and hypovolemia. While in pregnant lady, if the patient is in shock with positive free fluid intraperitoneally, that will equate to ectopic pregnancy. It is very important, therefore, to integrate the point-of-care ultrasound findings with the clinical presentation. So these are the examples of positive fluid collection in the intraperitoneal cavity. You can see thin hypoechoic stripe at the Morrison pouch as denotes by the arrow. There's a large subdiaphragmatic fluid collection at the left hypochondral region as well as in the pelvic region. Please be aware that it is not the bladder as you are seeing in the pelvic region, as the bladder is underdistended. A trauma patient in hypovolemic shock with these findings suggestive of intra-abdominal injury and warrant blood transfusion and urgent surgical intervention. A dengue shock patient with this finding suggestive of leakage syndrome. Here the clip A shows fluid collection in the right pleural cavity and also at the tip of superior pole of the right kidney. Clip B is taken at the left upper quadrant where you can see large amount of pleural collection. The spine extends up towards the cephalic and there is absence of curtain sign. So these findings have to be correlated with the patient's history and clinical presentation. In trauma, the findings suggestive of hemothorax. In a patient with heart disease, it may indicate chronic failure. The last step of evaluating the tank is to look whether there is any compromise to the tank or not. This is caused by tension pneumothorax, where the shifting of mediastinum or kinking of the great vessel impedes the venous return into the heart, or the stroke volume which is being ejected out from the LV. I must emphasize here that tension pneumothorax is a clinical diagnosis. Ultrasound utilization is only to rule out tension pneumothorax with the presence of sliding signs. Pneumothorax can be picked up by PoCUS in the absence of sliding signs, the presence of barcode sign on the M mode, the presence of lung point, and also the alternate barcode and seashore signs on the M mode. Please note that absence of sliding sign is not enough to say that it is a pneumothorax, as so many other conditions can cause absence of sliding signs such as pneumonia, lung contusion, and also pleural disease. So this is what sliding signs look like. Okay? The presence of sliding signs exclude pneumothorax by 100%, but only at the area explored. Clip A here denotes the absence of sliding signs. There is no shimmering light movement of the pleural line. If we put M mode onto the pleural line, a barcode sign will be produced as being visualized in still image B. Lung point is a more specific sign of pneumothorax. It is the point where a pneumothorax meets a normal aerated lungs. When the patient inspires, the normal lung will expand and sliding sign can be seen. Hence, we will see the absence and the presence of sliding sign alternately with patient respiration. Change into M mode, we will get a features what we call alternate seashore and also barcode signs. A PoCUS in pneumothorax will yield you different finding at different location. If you put the probe on subcutaneous emphysema, we will get numerous vertical lines arising from the subcutaneous tissue, which we call E lines. Put the probe on the pneumothorax area, we will see absence of sliding signs. If we locate the probe at the junction between normal lungs and also a pneumothorax, we will discover a lung point. Now we have finished assessing the tank. We move to the next assessment, which is the pipe system. Here we will scan the aorta from its root extending to the arch, then the abdomen until it bifurcates into the common right and also left iliac arteries, looking for any leakage of the pipe. We will also scan the vein at 2 points to look for any obstruction. We will use the cardiac probe to visualize the thoracic aorta, abdominal probe to look at the abdominal aorta, and also linear probe to picture the lower limb veins. An aneurysm is identified when the aorta diameter is more than 3 cm in short axis. It commonly ruptures when the diameter is more than 5 cm. It may not give us a positive fluid collection in first assessment, as the aorta normally bleeds into the retroperitoneal space. An aortic dissection is recognized by the presence of intimal flap floating in the artery. If the dissection occurs at the proximal aorta, it may be accompanied by aortic regurgitation and also pericardial effusion. Here, clip A shows a dilated aorta in the short axis measuring around 5 cm. The wall is surrounded by thrombus. Clip B denotes a dilated aorta on its longitudinal axis. Clip A here is the parasternal long axis of the heart. Can you see the dilated aortic root measuring approximately 10 cm? And this floating hyperechoic structure is not the aortic valve. That is the intimal flap due to the torn and dissected intimal layer. Clip C shows the intimal flap in the parasternal short axis at the base of the heart. This is an example of aortic arch dissection. We can visualize the intimal flap floating in the entire of the aortic arch. Change into the color mode, you may see a double lumen flow separated by the flap. Here the aorta, the abdominal aorta, measures less than 5 cm, but it is clearly dissected with the presence of intimal flap in both short and also longitudinal axes, as denotes by the red line. The next step of PIPE's evaluation is to look for obstruction. Assessment of the venous obstruction is indicated in the suspicion of pulmonary embolism. Majority of PE originates from the lower limb DVT. Hence, a RUSH protocol advocates a limited compression evaluation involving the common femoral vein, proximal femoral vein, and also popliteal veins. The pathognomonic signs is the incomplete compression of the anterior and also posterior wall. This can be performed rapidly with high accuracy rate. So here, clip A shows a compressible right femoral vein. Clip B shows non-compressible left femoral vein due to the presence of thrombus. You can see the anterior and posterior wall of the femoral vein does not meet each other. In here, clip A shows a compressible right popliteal vein. Clip B shows a non-compressible left popliteal vein due to the presence of thrombus. So in summary, RUSH protocol involves 8 steps of PoCUS assessment on the pump, tank, and also pipe system. In the pump or heart evaluation, look at the surrounding of the heart, then evaluate the left ventricle, and next the right ventricle. Proceed to the tank assessment, looking at the fullness or the volume status, any leakiness or any compromise to the filling or emptying of the tank. Lastly, we assess the pipe, whether there is any leakiness or obstruction to the arterial and venous system respectively. So what can you see in hypovolemic shock? In hypovolemic shock, you may see hyperdynamic heart with small chambers. In the tank assessment, you can see flat IVC or flat IJV with peritoneal fluid and pleural fluid collection. A positive fluid in pleural or the abdomen may indicate bleeding in trauma or leakage in dengue. You may also find abdominal aortic aneurysm or aortic dissection as the source of hemorrhagic shock. Cardiogenic shock is suggestive with the presence of hypocontractile heart or dilated heart size. You may also see distended IJV or IVC with numerous B lines in the lungs indicates failure or fluid overload. You can also see pleural effusion and ascites during tank assessment. The pipe in cardiogenic shock may appear normal. Obstructive shock is evidenced by pericardial effusion in cardiac tamponade, RV strain pattern in pulmonary embolism, absence of sliding signs in tension pneumothorax, and in the pipe assessment, you may find DVT which will be present in pulmonary embolism. Distributive shock is a bit unique. In sepsis, the heart may appear contracting vigorously and hyperdynamic as it contracts against a very low resistance in the early stage. However, in the later stage, with the presence of septic myocardium, the LV and RV may be affected. The IVC and IJV may appear small or normal. And you may find source of infection, for example, pleural fluid in the case of empyema, peritoneal fluid in the case of peritonitis. As we know, there are many ultrasound protocols created for many clinical scenarios. So what are the differences between this protocol? Different protocols give different priority. They normally start with PoCUS cardiac ultrasound, followed by incorporation of lung ultrasound, FAST, aorta, and DVT scanning as being dictated by the clinical picture. As you can see here, RUSH has one of the most extensive assessment involving 8 steps compared to other protocols. However, as you do focus upon point-of-care ultrasound every day, regularly, you will develop your own steps and you will adjust it with different clinical setting accordingly. Now we have reached the last part of my presentation, which is the case scenario. So now let us look at some case. Case number 1 involved a 51-year-old man who complained of chest pain 4 hours prior to arrival, and this associated with sweating and also nausea. He was hypotensive with cold peripheries. The lungs shows bivessel crabs, cardiovascular examination, and abdomens are normal. He had no pedal edema. This ECG shows a ST elevation MI at the LAD territory with reciprocal changes at the inferior leads. So what is the role of point-of-care ultrasound here? Clearly, this patient has cardiogenic shock secondary to acute anterior STEMI. We can actually evaluate the regional wall motion, look at the complication of STEMI, such as ventricular free wall rupture, papillary muscle rupture, formation of thrombus, and more. However, these are not covered in this basic PoCUS series. However, here you can see hypokinetic or almost akinetic anterior segment of the left ventricle. The left ventricle contractility is reduced to 30%. And we know that this patient requires inotropic support and also emergency reperfusion therapy. In the lung scan, the base of the lungs showed B lines indicating left ventricular failure. So this patient requires double antiplatelet, inotropic support, reperfusion therapy in the terms of PPCI or thrombolysis. Case number 2 involved a 70-year-old male who complained of back pain followed by an episode of syncope. He was pale with reduced pulse volume. He was also hypotensive. The cardiovascular system, the lungs, and abdomens were all unremarkable. So from the assessment of the pump, there is no pericardial effusion seen. The left side of the heart shows normal LV function, and there is absence of RV strain pattern. So clearly, this is not cardiogenic in origin. As the patient is pale and also hypotensive, we have to look for evidence of tank or pipe leakage. Here, there is abdominal aortic aneurysm. However, there is no free fluid visualized intraperitoneally. A ruptured AAA diagnosis was made. It most probably ruptured into the retroperitoneal cavity. This patient requires resuscitation, including blood transfusion, and also preparation for emergency laparotomy and also vascular intervention. The third case is quite unique. This is a 79-year-old male, post-op day 2 with a KBH. He underwent KBH with a 3 graft. He was actually extubated well 6 hours post-op. However, we were not able to wean off the IVI adrenaline due to borderline blood pressure. An episode of delirium settled with haloperidol and also quetiapine. He, however, developed bradypnea and subsequently intubated. He was persistently hypotensive and the requirement of IVI NORAD increasing with time. The chest drains were not increasing in amount and upon assessment, we could not find any evidence of acute bleeding, ischemia, infection, or even electrolyte imbalance. We then review the chest X-ray, and you can see the heart silhouette increase in size from day 1 to day 2 post-op. Next, we perform focused cardiac ultrasound. As expected, there was pericardial effusion accumulating surrounding the heart with fibrinous-like structure. It was actually difficult to view the entire of the heart with the sternal dressing and the chest drain at the subcostal area. We tried to visualize the heart at every angle that we can. Then we found some loculated effusion compressing the LA chamber in the apical 2-chamber view. We measure the stroke volume, or actually the surrogate to the stroke volume, which is the left ventricle outflow tract velocity time integral, which was only 7. The normal value is 14 and above. So we made the diagnosis of obstructive shock secondary to cardiac tamponade due to loculated effusion. He underwent some intervention, and post-intervention assessment shows the effusion was completely drained and there was no longer compression on the left atrium, and also the stroke volume improved to 16.9. This patient progressed well, the adrenaline was weaned off, and he was extubated and discharged well from the cardiac ICU. My last case involved a 40-year-old male. He was referred to me with decompensated dengue shock with positive NS1. He was already given 30 ml per kg of fluid resuscitation, however the blood pressure remained low. The BP was 70/50 with heart rate of 70. His peripheries was warm with bounding pulses. Then we performed point of care ultrasound. Assessment of the pump shows no pericardial effusion. The left side of the heart shows good contractility without any RV strain pattern. So the LV and diastolic area and also systolic area shows adequate fluid. There was no kissing wall. There was no meeting wall of the left ventricle, and here there was no pattern of hypovolemia. Further assessment shows there is no evidence of leakage, no pericardial effusion at the subcostal area. The pleural effusion was also absent, nor there was ascites. The bladder was well distended. So then we make some deduction. The contractility here is normal, volume is adequate, there is no sign of obstruction, hence the stroke volume is not the problem. So we confirm this by measuring the surrogate of the stroke volume, which is the LVOT-VTI, and it was 20. It is normal. In conclusion, we are dealing with distributive shock, which requires some vasopressor. This patient responded very well to IVI, noradrenaline, and later was put on maintenance feed infusion. This is an example of dengue shock, which requires vasopressor support, as we are dealing with vasoplegic shock. PoCUS provides a very objective assessment and facilitate decision-making in this case. We have come to the end of this lecture. I hope this lecture provides you some valuable knowledge of PoCUS utilization in shock. Ultrasound protocol serves as a systematic way to assess a patient in shock, which allow us to identify the type and the cause of shock, and also provide us the opportunity to intervene timely, hence reducing the mortality rate. But remember, PoCUS is just an adjunct to complement our history and also physical assessment, and accurate decision-making requires correct image acquisition technique and also knowledge to integrate the findings with clinical condition. Thank you for listening, and good luck.